This is week one, the second part of the video for foot and ankle. Just as a quick apology, I am sorry for any grammatical errors and for you having to hear my voice. But again, we're going to look at the foot and ankle. It is crucial that you understand the very intricacies that are part of this complex. Majority of our patients have some type of lower limb issue that they're coming and seeing us for. So it's important to make sure that you are able to provide them with the best care possible because you know your anatomy. If I am unsure about a decision that I'm making in class or in lab, or I'm not completely confident in my course of treatment, I fall back on my anatomy. It's my rock. It's what I know. It's what I understand. And if I am able to have a firm grasp on that, then I'm able to use that skill set to make the best decision for my patient. So it's kind of like my comfort zone, my place that I can run back to and say, okay, well, I know how this works, and I know how this works. So theoretically, I can do this for this patient. So let's go ahead and get started with the foot and ankle. All right. So a quick review. You should remember this from your anatomy course. We are going to start with bare bones. So the bones of the foot. How many bones are in the foot? 26 bones in the foot, and the foot is divided into 3 regions anatomically, and these 3 regions are called what? Yes, the hindfoot, midfoot, and forefoot. The hindfoot is comprised of 2 bones, the midfoot 5 bones, and the forefoot are the remainder 19 bones. So let's go ahead and take a look at a 3D image of the foot. Alright, so I am using anatomyzone.com and the biodigital human format for this 3D model of the foot. Go ahead and ignore these little dots. They represent other anatomical structures in space, so just try to ignore them because they'll come up later when we look at the other aspects. So let's get started with just orienting ourselves with the foot. If we're going to look at it from an aerial view, which is the way a lot of people look at the foot when they divide it into the regions, it kind of visually is easier to see. If we're looking at the aerial view, are we looking at the dorsal or plantar surface of the foot? We're looking at the dorsum of the foot. Again, like a dorsal fin on a shark or a dolphin or whatever. It's going to be on the top or more superior, and then the plantar surface is going to be planting on the ground, right? So dorsum sees the sun, plantar is on the ground. All right, just to review. So now let's look at the proximal and distal. So our toes out here are going to be more distal to the body. That's up here, right? And then our heel is going to be the more proximal segment. All right, let's look at the regions of the foot. We're going to start with the hind foot. So what 2 bones make up the hind foot? Calcaneus and talus, yes. So we have our calcaneus right... Oh, I'm sorry. Okay. We have our calcaneus right here. Oh, look, it labels. And then we're going to have our talus right there. All right, so let's talk about this calcaneus for a second and figure out what he's all about. So the calcaneus is both the largest and strongest bone in our foot. It has this posterior calcaneal tuberosity that, when you grip onto someone's foot pretty good, you are grabbing, this part was what we kind of consider the heel, but you're grabbing on right here to this tuberosity. It has 3 facets that allow it to articulate with the talus, again up here, and the cuboid. So, a misconception that I always had, here's our cuboid, or always thought, was that this was all just kind of a jumbled mess and they all just kind of glide around on each other. No, they have very, very specific articulations that allow them to move in specific ways. One thing to note that I didn't always know was that the calcaneus does not articulate with your navicular right here. So it's only articulating with your cuboid and the talus on top of it. Again, we're on the plantar surface of the foot right now. Here's our navicular. So it articulates with our cuboid and our talus up here. All right. So whenever you do palpate someone's calcaneus, a lot of times we'll have patients in with plantar fasciitis, which is the inflammation of the plantar fascia, which we'll talk about more later, that runs right here. And a lot of people have pain right in this area in the morning, especially. But a lot of times they have pain, so sometimes we'll palpate under here just to see what exactly is going on. So when you do palpate the calcaneus, you want to palpate the posterior and plantar heel region. We also know that our Achilles or calcaneal tendon inserts on this calcaneus. So by pressing on this heel region, we can see if perhaps our patient has some of this tendonitis or abnormal bone formation because different tendons are pulling on the bone in certain ways. Does anyone remember what the name of that law is for when there is stress put on a bone and bone growths occur? Wolff's Law. Wolff's Law. All right. So we know almost sometimes how bad this tendonitis or inflammation is based on the pain that our patient is experiencing. So sometimes they'll get a little heel spur right here, which is just a little bony overgrowth from the plantar fascia that's stretching along the foot, or sometimes they can have little heel growths or problems with the calcaneus from the Achilles tendon inserting down here. All right, so that's our calcaneus. Let's go ahead and look at our talus, which is this bad boy. All right, so our talus is the other bone that's in the hindfoot. Its head is going to be, let's zoom in on it a little. All right, okay, so its head is going to be right here, and then the neck is this little groove. This whole area is considered its body with this slope that's on top. Anyone remember the name of this slope on top? Right, it's the trochlea. Kind of like in the humerus, this how it has like a trochlea, this sloped area. This also, the talus also has one. And I'm pretty sure trochlea actually refers to a structure that's like a pulley shaped, which that kind of makes sense if we look at it. It definitely has this pulley shape to it. But this allows for our tibia and fibula to progress over the foot throughout gait. So when we're at mid stance, it's going to be about neutral, and then as we come over, this is going to allow us to go into dorsiflexion. Okay, so we'll talk about more about the talar. We will talk more about the talocrural joint at a later time. But something that I want to point out also about the talus. Let's go over its articulations. So it's going to articulate with the tibia and fibula as part of the talocrural joint, with the calcaneus, which we already talked about it articulating with, and then also the navicular. So going through gait, we're getting a little ahead of ourselves, but as we walk, right here, this talus and calcaneus are going to push on the navicular, and so this whole thing is going to drive all the other bones. Okay, so it's almost like I don't want to say a car accident, but a domino effect. Okay, so as this one pushes and as we move through, it's going to push all the rest of the bones, and all these different little articulations cause the foot to move in a very, very specific way. Okay, all right. So let's look at the talus from the dorsal side. As we can see, let's move it this way. All right, so the talus has something kind of cool about it that I recently read about, and I don't really remember learning in my anatomy class, but that it is much wider. I'm sure I was taught it, and I was just maybe zoning out that day. Anyway, let's not zone out. Okay, so the talus is much wider anteriorly than it is posteriorly. So, what difference does that make? Well, humor me for just a second, and if you're able to, go ahead and stand up on one foot and raise your other foot off of the ground, okay? All right, and so if you're able to stand up on one foot safely, go ahead and plantar and dorsiflex your foot back and forth a few times with me. All right, now I want you to go into plantar flexion and invert and evert your foot. Fairly easy, right? You get quite a bit of motion there, huh? Okay, now slowly raise your foot and go into dorsiflexion and try to invert and evert your foot. It's a lot more difficult, right? You don't get as much motion. It's also kind of hard to do this. It kind of takes coordination. Anyway, so as you can tell, I am not able to invert and evert as easily in the dorsiflex position as I can while I am plantar flex. So, what does this mean when we're talking about that wide anterior talus? Well, you can tell that that wide anterior talus is what is the primary cause, or one of the primary causes, of increased ankle stability during gait, especially. So we're not going to talk about this right now, but just remember this when you're learning more about gait and in biomechanics and in other classes, that this talus, the way it is shaped, is very purposeful in driving some movement. So it's not going to allow a lot of ankle instability in dorsiflexion, which is important to maintaining safety and being able to progress over the foot in an appropriate way. So you'll learn more about that, but just kind of remember that that talus has that wide anterior. So as your tibia and fibula progress over the ankle throughout gait, especially in dorsiflexion, so think on that foot, terminal stance, pre-swing, as that foot is dorsiflexed, what is happening to the ankle and to the rest of the foot? What are the joints and the rest of the foot doing? So just keep that in the back of your mind. All right, we're going to go ahead and take a look at our midfoot now. So what 5 bones make up the midfoot? All right, our navicular, cuboid, and the medial, intermediate, and lateral cuneiform. So let's ID them real quick. Here's our navicular, then we have our cuboid over here, our medial cuneiform, our intermediate cuneiform, and our lateral cuneiform. All right. So let's take a look at our navicular first. He's a pretty important guy. I don't like the setup of this too much and how it lays in relation to this cuneiform. Certain things about it I wish it was displayed better, but it's okay. Anyway, sorry. So the navicular is a pretty flat bone for the most part. You can see it's pretty flat straight down. There's nothing too crazy about it. But this picture, what it doesn't really show very well is the tuberosity that's right here. It marks it, but anyway. So there is a tuberosity that is easily palpable and is very close to the surface of the medial side of the foot. We have to pay very important attention and close attention to this, especially in lower limb orthoses, because it can easily cause skin breakdown if it's not accommodated for, and if an area of relief is not made for this tuberosity, then it easily can shear against the orthosis and cause damage and not a lot of fun to our patient. So definitely an area we need to look out for. According to Newman in your functional anatomy book, that kinesiology book, the navicular tuberosity, so right here, this bad guy, is located about 2.5 centimeters inferior and distal to the tip of the medial malleolus. So our medial malleolus is out here in space, right? It's probably up here somewhere. So again, it is roughly 2.5 centimeters inferior, so down, and then distal to the tip. So let's go ahead and look at a picture of my foot real quick, and I will explain that a little bit further to you, okay?